So good afternoon, everybody. I'll be talking on the Raynar hydrophilic IOL, the EV lens, which is called the intermediate vision lens. I would like to concentrate more on the materials that the Raynar house of lenses they come with. This is a hydrophilic acrylic lens, and which is normally in a dry state. It is supplied in water and becomes swollen. And there are different kinds of hydrophilic materials that are available in the market. And this is one of the very old lens which has been time tested, and the material is one of the best materials that is available. See, what are the advantages of the hydrophilic IOLs over hydrophobic IOLs? See, overall, the hydrophilic IOLs have the best UVL biocompatibility. So that is the most important thing I want people to understand. The hydrophobic IOLs are only capsular biocompatible and they don't have the best UVL biocompatibility. And hydrophilic IOLs, they very closely resemble to the human tissue in terms of the water content. So they adjust very well to the eye. And the opening of the lenses is also very predictable. And they don't, temperature dependent. For example, if you're implanting a hydrophobic IOL in a very cold atmosphere, then the lens tend to become very hot. So Raynar comes with a very good cross-linked polymer, excellent shape recovery, and it is the damage by Nd:YAG lasers is also very less. The only disadvantage of the hydrophilic IOLs is the chances of PCO is much higher, and the chances of calcification is higher in hydrophilics. That is what is described, but I have never really seen any calcifications of the present generation hydrophilic IOLs. See, the only problem what people talk about hydrophobic IOLs is the PCO rates are very less. And what is the problem in doing a YAG capsulotomy in a pseudophakic eye? When you are opening the posterior capsule, it tends to wash out the hyaluronic acid from the vitreous, and then that can result in a collapse of the vitreous body, can result in acute PVD. When there is an acute PVD, it can result in retinal tears and retinal detachment. So that is the basic funda why you don't want to do YAG capsulotomies after PCOs, and so you want to prevent PCO. That is where the hydrophobic lenses actually come into play. So in vascular disorders like diabetic retinopathy or vein occlusions, the vitreous actually undergoes a cross-linkage and there is an abnormal strong adhesions of vitreous to the retina. So the PVD generally does not happen in diseased eyes. So when this happens, there is no question of PVD, there is no question about having a rhegmatogenous retinal detachments or retinal tears post YAG capsulotomies. In vitrectomized eyes, obviously there is no question of vitreous, there is no existence of vitreous. Even if you do a YAG capsulotomy, the patient, the retina is always very safe. So that is the basis of using hydrophilic IOLs in a patient. So Raynar comes with a very proprietary hydrophilic acrylic biomaterial. Okay, this is the material they use. So what is very important is the exceptional high UVL biocompatible to hydrophilic IOLs, which is very much suitable for uveitic and diabetic patients. It is suitable in pediatric eyes, and the square edge model is very important in prevention of PCO, though the PCO rates are pretty high in hydrophilic IOLs. It is also suitable in combined phacotrabeculectomies also. And what is very important is patients who have a chance of undergoing vitrectomy and silicone implantation. It is important that you implant hydrophilic IOLs rather than hydrophobic, because the silicone oil does not stick to the hydrophilic lenses. These are some of the examples I want to share. These are some of the hydrophobic IOLs where there is opacification of the entire optic of the IOL. And you can see there is a central opacification of the lens after about 2 years of implantation of a hydrophobic IOL. This is one of the Indian hydrophobic IOLs that I have implanted. These are the pigment deposits of hydrophobic IOLs. You can, because of the pure biocompatibility, you can see a lot of pigment depositions in uveitic eyes and short eyes. And the central lens is of a PMMA lens. And there is also pigment dispersion on the third picture. So Raynar has come out with enhanced monovision eyes and trifocal eyes. I'll just want to share the Raynar EMV concept, where they have a centrally induced spherical aberration and a negative aberration, where you can get an intermediate vision along with distance good vision. So it is a lens, but because of the spherical and negative aberrations that I have created in the center, it creates about a 1.5 diopters of near vision also, which gives you a decent intermediate vision. And because there are no rings in such eyes, obviously the patient will not have any glare issues. So these lenses will give you a good depth of focus for day-to-day life. As you can see, there is about that 1.5 diopters of normal IOLs, but in EME lens you get about 1.5 diopters of intermediate vision. So these are various examples. What have the so Renard, it gives a superior intermediate vision, offers 1.5 diopters of extended range of vision, and even if you miss the target of the refractive target, it can resist a little 1.5 diopters. It complements the natural of the spherical aberrations reduced because of it is only in the central part. It is not pupil dependent. I'll just skip all these slides. I just want to share. So this is an example where I have done. This is the Renard lens that I have implanted. I always do a very good anterior capsular polishing, because to prevent remove as much of the equatorial cells as possible and implant. This is the preloaded EME lens that has been implanting. You can look at the way the lens comes out and smoothly unfolds, and the predictability is beautiful. So this is the second post-operative. This is the lens that has been implanted. It has got a very good shine. The clarity is beautiful. The capsule is very nice. And these are the situations where, for example, in this case, I have an extended rhexis, and there is a chance if you tend to implant a hydrophobic IOLs in such eyes, you can see there is an extended rhexis. So the optics are exposed to the uveal tissue. In such situations, I generally don't tend to implant hydrophobic IOLs, rather than I implant these hydrophilic IOLs. Once you don't have a very good capsular rhexis, Sandeep, the chance of PCO is also. Yes, sir. This is also one of these things I want to share. This is a patient who has underwent vitrectomy and has got a dispersed vitreous hemorrhage. So what I am trying to do is, I am removing the posterior capsule in this eye and absorbing and removing just using a 26 gauge needle. I created a PCR and removed the dispersed vitreous hemorrhage from the vitreous cavity. So by this, actually, you're actually making the entire eye into a single chamber. The posterior chamber and the anterior chamber made into a single chamber by removing the posterior capsular. The membrane between the anterior and posterior capsular membranes, the chambers are separated. So that for these things to happen, even if the patient develops a dispersed vitreous hemorrhage later on, the posterior capsular opening that you have made, the fluid from the vitreous cavity can come into the anterior chamber, and the vitreous hemorrhage can resolve by itself.
Time's up, please.